and hope everyone's having a good week so far. So Healthwatch. So we've been wanting to run this webinar for a while now. We know from the network survey we did with members at the end of last year, and from a number of our discussion groups, that people are really keen to know more about the work of Healthwatch and the role that volunteers are playing in helping to address health inequalities locally. So we're really thrilled today. We've got 3 speakers who are going to help us to understand the brilliant work the organisation does to bring the views of the public to NHS leaders and decision makers, and also be a health and social care champion for local communities. So in a moment, we're going to hear from Gavin McGregor. Gavin is Head of Network Development at Healthwatch England. Then we've got Andre Benham. Andre is Volunteering in London Regional Network Manager with Healthwatch England. And then we're also joined by Sheila Burridge, who's Volunteer Officer at Healthwatch Somerset, and is going to bring things to life with examples of how volunteers are contributing in practice. So I hope that's what you were expecting. We really hope you enjoy the next hour. We've allowed about 20 minutes for questions after the presentations. Some people have sent their questions in advance, and we'll add those to any that you might like to raise in the chat box during the session. I think Debbie has organised for all the cameras and mics to be switched off, but feel free to turn them back on during the Q&A towards the end. We've just done that to reduce the strain on the tech, so I hope that's okay. So I'm going to hand over straight away to Gavin now. Welcome, Gavin.
Well, thanks very much, Sally. It's a really great opportunity to come along and talk about Healthwatch and meet you all as well, because it's really important that we are connected in at local levels. And somebody else has got their mic on, I think. So, yeah, brilliant. Thanks. So I'm going to talk about Healthwatch. So apologies to anybody who already knows. I can see people on the call who will probably know this even better than I do. So apologies for people who already know about Healthwatch, but I thought it'd be useful to cover exactly what we do. And as Sally says, we are the health and social care champion. We actually have a statutory role, so we're set out in legislation to deliver statutory activities. And it's really, we're here for anyone who uses health services or needs care. So anybody who uses sort of publicly funded services, so that could be social care, it could be health services, the whole range. So it's a huge remit that local Healthwatch have got to carry out. We've got a pretty simple tasks, and that is to hear about people's experiences. And to crucially to make sure that those experiences help to bring about improved services and care for people. So that's what we're really about, and including, tackling inequalities around that as well. So just a little bit about our structure. So as Sally pointed out, we've got an example of how we work, because we're Andre and myself, we're from Healthwatch England, the national body. And we oversee the network of local Healthwatch, but also help to inform policy and services at a national level. So taking all the fantastic insight that local Healthwatch generate and using that to help improve policy and services at national level. But every local authority area in the country has a local Healthwatch. So all 153, so that's the upper tier local authority areas, has a local Healthwatch. And as I say, we've got the power to really ensure that NHS and social care leaders listen to the feedback that we hear from the public and improve standards of care. And the other aspect of the statutory activities is that we provide advice and information so that people can really find out what help is available locally. So really, you should be able to pick up that local Healthwatch really need to be plugged into their local communities, and they also need to have a really good understanding of their health and social care services. So absolutely crucial about knitting in with, I'm sure with all your roles. And in terms of the volunteers, they will probably be, I'm sure there's some on the call, but there'll be likely wearing more than one hat. So they may be volunteering for a local Healthwatch, but they may be volunteering in other organizations, whether it's other charities or with the NHS as well. So hopefully you do know people who are already doing that kind of voluntary active. You might not know they're actually doing that for Healthwatch, but I'm sure many are. So next slide, please. So this is our standard template. So what we're trying to do here is make sure everybody gets the care they need. We're all in this together. So very much that bigger vision around that. And our specific role is to make sure that those people's experiences, say, help make health and care better. Our values, we've just done some real work across the network on these, and they very much speak to, what drives us, what motivates us as a network of organizations. So really crucial, I said, around tackling health inequalities. So that equity thing, making sure we do listen to people and give them an opportunity to have their voices heard. And we do that in a compassionate way. So that link to communities is absolutely vital. And yes, it's absolutely about empowering them, so enabling them to have a voice. Collaboration, it's good that we're on this call today, because I think there might be questions around this. Absolutely about local Healthwatch building relationships. So you should be expecting them to be connected in with all the health services and their community relationships as well, both in terms of internal and external communicating. And you will see that most, Healthwatch, an ethos is around co-production. So really working with partners to help, get solutions to the issues that and the challenges that they come across through the public. And yeah, we're not just here to make sure that voices are heard, but we actually want to see a difference. So our agenda is driven by the public. So we are independent organizations. So we've got a careful balance to be done around holding decision makers to account, but also acting as a critical friend to really try and find solutions to those issues and bringing attention to the issues that the public are expressing. Yeah, so I won't go over all of them, but yeah. Like any network, we're quite a varied network. So nationally, we've got about 37 staff, but as I say, we've got 153 local services, and a typical Healthwatch. I don't know if there is a typical one. We've got a range, but a typical one would be about 4 staff, about 20 or so volunteers, budget ranging from 100, about 150,000. So so they are relatively small organizations, and going back to that large remit, then they've got a challenge on their hands around that. So I say there's quite a lot of variation across the country. So they really do need to use their resources really carefully and wisely. And the contribution of volunteers is absolutely crucial to that as well. Yeah. So just to give you a sense of we're 10 years old, so that's us. We've been going for about 10 years now, and last year we reached about 1.5 million people with information or to have a say on their care. So there's some stats there around the numbers, but locally, that's nearly 1 million people that were getting help through information advice, and about 400,000 people who shared their experiences of care. So a big reach. Just before I hand over to Andre to cover the next slide, it's useful to say that Healthwatch and Healthwatch England is subject to review at the moment. So we're awaiting an outcome of something called the DASH review. So we're awaiting to see what our future role is going to be. So it's a critical moment. We're in a really good position, we think, as we've just set out. And I'd just like to end by 3 examples of the difference that local Healthwatch have made. So I see we've got Leeds on there, so let me demonstrate Leeds. They did a huge exercise listening to lots and lots of people across Leeds to really inform their social care plan and really make sure that the people's voices really informed that. We've had an example in Birmingham where they listened to Black African and Black Caribbean people's experiences of maternity services and really got changes then making accessibility around that. And similarly around maternity for refugees and asylum seekers in Coventry, and again, changes around accessibility, practical things that resulted from that. And then Blackpool, they looked at, listened to young people around vaping and really brought those issues to account, not just in Blackpool actually, but nationally as well, which led to a change in policy. So on that note of the kind of difference, I'll hand over to Andre.
Lovely, thank you, Gavin. So just briefly to kind of go through, obviously already kind of said the number of volunteers, but just kind of as part of that review and what's kind of gone over the last decade, you know, you can see there from below the funding has gone down somewhat. Our level of staffing nationally hasn't greatly changed. It's gone down slightly, which, as you can imagine, with the reduction in funding, still trying to do the large remit that local Healthwatch have to do. But actually, the volunteer effort has continued to grow. And I think there's multiple reasons there. You know, as per a lot of the services, VCHE sector organisations, NHS Trust, many of you, I'm sure, on the call are very used to funding windows and packets being reduced. It's very commonplace. So having to deal with that. But, you know, the volunteers, we have got a large range of volunteers that will actually be celebrating some for Volunteers Week in June this year that have been with the service since the inception, so 10 years, which is absolutely phenomenal. You know, lots of others that have got 5, 7, 8 years, but to volunteer for that long with that effort, with that passion, is just incredible. And as Gavin kind of alluded to, a lot of the volunteers work elsewhere in the health sector or social care sector or volunteer elsewhere as well. So again, hopefully they're all kind of in there, and that collaboration piece of trying to bring those people together, bring our services together to help each other wherever possible. So what I just kind of want to go through is my role at Healthwatch England. Whilst we have a board, we don't have volunteers on a national basis. It's the local Healthwatch that do. So my kind of role is to make sure that there's national support for our volunteers leads. So first and foremost, we hold a quarterly meeting for our volunteer leads network, which actually this year we made the decision for it to be hosted by the network for the network. So rather than me run it, who doesn't manage volunteers, we had different people run every session with their own ideas, their own agendas, listening to the network, because they're the ones that live and breathe this day in, day out. They're the ones that know the challenges they face, what they have to achieve, what questions come up, and how to deal with that. On top of that, we offer learning and development opportunities. So some of those we've run internally, depending on what it is. So it might be myself, it might be, you know, if it's on impact, our project manager who leads on impact. But we also have commissioned and paid for other training, such as this year we had NCVO run some training on recruitment, induction, management of volunteers. So a wide range of kind of opportunities as well. And wherever possible, we try and listen to the network, what they want, what will benefit them, what is needed. Kind of, you know, a lot of it is about best practice sharing. So we've got a engagement platform. It's kind of Facebook currently until it closes, which we're just changing, but we will still have an engagement platform for and a specific group for volunteer managers to join. They can talk to each other, they can ask questions, they can share files, best practice. We offer kind of we offer media and comms support, so we've got different teams that can do different things. But you know, whatever we can do to support, guide, help. You know, we've got a big bank of resources on our what we call our network site, so staff and volunteer side of our website for them to access. So we've got guides on there, lots of different kind of resources. I think, you know, alluding back to what I was saying around kind of some of the long-term volunteers that have been with us for, you know, up to 10 years, it's again, probably many reasons if you've got volunteers as well, similar to others, is the focus around health and social care element and being in part of that change locally. So, you know, we make sure that the benefits and try and help volunteer leads make sure that those benefits are clear. You know, they're contributing to something that hopefully is genuinely changing people's communities, their health communities and their services. But, you know, there's also learning and development opportunities for them. We want to make sure that they're being developed, they're being able to, and lots of the long-term volunteers have stayed in place because they haven't just done one role, they've moved around, they've tried different things, they've developed. With lots of them, you know, I've got some examples off of the last meeting we had a couple of weeks ago where, you know, we've got volunteers now that are basically project managers. They are running their own projects within Healthwatch, which is just fantastic, you know, from 3-4 years ago where they started with Healthwatch. But, you know, it's also the community element, getting to meet each other, connect with others and being part of that community. In terms of kind of the resources and what was helped, which I just kind of wanted to go through, we come up with kind of 12 main volunteer roles. So I've put those on the screen just for reference. But we worked with the network, so all the volunteer leads, and come up with what are role descriptions. Main thing is so then it helps people who maybe can't think outside the box and think, you know, what can a volunteer do? Well, here's 12 different things already without thinking too far outside the box that they could get involved with. It also means that, you know, as Gavin said, an average Healthwatch may have 4 staff members. Quite often volunteer leads are also doing other roles. So again, to try and ease that, we've got a big document, a guidance with all of these all of these role descriptions in with some other information to help. They can pick them up and use them as they are, or they can adapt them to what their local offer is, but they're there. And that's kind of one of the examples of the sorts of things we try and do to help and offer. But it's always done with the network. It's always done. Sheila's on the call and has helped us out with some new e-learning that we put together this year that's been released, or last year that we released this year. So yeah, there's many things, but we always try and work with the network to understand what they need, what they want, and how to push that forward. But as I said, in terms of the living and breathing of volunteers, that's why we've got Sheila here today, who is the volunteer officer from Healthwatch Somerset. And if I can, I'll pass over to you, Sheila.
Thanks, Andre. And are you happy to move the slides on as and when?
Yep.
Great.
Yep. Just let me know.
Thank you. Good morning, everyone. I'm Sheila Burridge, volunteer officer at Healthwatch Somerset, and my role is to recruit and manage a group of volunteers. And I'm just going to start by saying the photograph that you're looking at there, 2 of our volunteers, Tony and Sue, off on duty in a hospital, Yeovil Acute Hospital. They were doing some questionnaires and surveys in the A&E department. So yeah, 2 real life volunteers. Next slide, please. We're fortunate to have a team of around 30 volunteers who help us carry out our work. So a couple of photographs there. The one on the left, our volunteer Tim and myself, sunny Somerset day at the county cricket ground. We were helping our NHS and public health colleagues with a blood pressure monitoring session. So across the summer, there was a real initiative around people getting their blood pressure tested. So in libraries, public events, supermarkets, other places like that, the NHS and public health, and we supported them. We went around and were sort of cajoling and nudging people to go and get their blood pressure tested. So that's the photograph there. The one on the right, we offer learning, training, development days for our volunteers, usually have a couple of those each year. And so there they are, all looking very happy, which is a very good sign, obviously enjoying the tea and cake that we provided for them. But yeah, a group of our volunteers there at one of our development days. Next slide, please. We're a small staff team, just like Gavin and Andre said, most of the paid staff around the Healthwatch network, small staff team. So we really rely heavily on our volunteers to help us carry out our work, and they're an integral part of all we do. So we rely on them, our volunteers, to support us by attending focus groups. You can see a picture of our the bottom centre picture, our volunteer Richard with the blue jumper on at a focus group for young carers. The photograph on the left, our advisory board chair Judith there chatting to the local mayor in a town centre event that we did in the summer. And then the other couple of photographs out and about at events, so talking in public libraries, supermarkets, and joining events. Thanks. Next slide, please. Some of the things our volunteers do: speaking to young people at fetes, fun days and youth groups, carrying out visits to care homes and hospitals under our Enter and View work, which allows us to go and visit services where public money pays for those services. So that could be care homes, hospitals, GP surgeries. Our volunteers get involved in surveys. We've got 2 volunteers who support a singing group for people with respiratory issues that's called Sing to Breathe. They help to publicise our projects, and they take part in focus workshops, for example, at carers groups. And the photograph on the left there is our young volunteer Willow, out and about at a family fun day, again in the summer. Next slide, please. Volunteers are our eyes and ears in their local community. So the stories and the feedback that they give us can influence our projects. So a few things there on that list. Volunteers told us that people were struggling due to pharmacy closures in Glastonbury. There were 3 pharmacies in Glastonbury, 2 of them closed, leaving 1. So we heard some personal stories about how people were struggling to access pharmacies. We heard about GP access issues in West Somerset and the difficulty getting ADHD medication in Bridgewater. Volunteers gave us personal case studies for our dental access report. And a couple of our volunteers shared their personal experiences of caring for a family member with social workers at a community training session. Next slide, please. Volunteers feel they can make a difference by speaking up about issues, sharing stories from their communities, encouraging their networks of family and friends to complete our surveys, taking a lay perspective when carrying out visits to services, and representing the public or patient voice when attending meetings on behalf of Healthwatch. Our advisory board of 8 members, all volunteers, represent Healthwatch. Again, because we have a small staff team, we couldn't possibly spread ourselves so thin to attend all the meetings that we get invited to. And so our volunteer board help us by representing Healthwatch at a variety of meetings. So that can include the local Safeguarding Adults Board, the local integrated care board. We have a statutory place on that board. And so, you know, our reach, as both Gavin and Andrea said, is really wide. We reach out across lots of communities, lots of meetings, you know, and we're invited to them. So our volunteers really help us to be able to fulfill our role by attending those. Thank you. Next slide. Most recently, our volunteers have attended a men's health event in Glastonbury, talked to carers at a carers assessment day, carried out a GP surgery visit under our Enter and View work that we do, supported us at a diversity celebration day, and chatted to people at a wellbeing mental health hub. So you can see the variety of work that we undertake is wide. And I just hope that this has given you a flavour of how our volunteers get involved. Final slide, please. Thank you for listening, and, you know, open up to any questions.
Thank you, Sheila, and thank you, Andre and Gavin. Really great overview, and lovely to hear the live examples of the impact volunteers are making at a local level. It's really inspiring, so thank you for that. So the floor is yours, everyone in the audience, so feel free to turn your cameras and mics on if you'd like to put your questions directly, or alternatively use the chat box. Just to reassure you that we will share the slides and recording as soon as we can after today's session. So we do have some questions that have been submitted in advance. So perhaps we could start with those and get the ball rolling. So the first one came from Gethin, who's interested in perspectives on quality standards in health and care volunteering. So innovative models of volunteering in social care, anything connected to, in particular, the NHS England Volunteering for Health Fund. So, Gavin, I wonder if I could put that one to you first.
Yeah, I don't know if we've, yeah, I'm probably going to be looking at Sheila as well, because I don't know if we've necessarily got quality standards for our own volunteers. So, and I don't know if we're actually plugged into that. So it may be one for us to pick up, Sally, afterwards, because I'm not sure if we're plugged into that at all. It might be, because I don't know too much about, I don't know if Andre knows too much about that one. So I'm sorry, I don't think we probably have a response to that specific one. In terms of the sort of quality standards for our own volunteers, I suppose the key things will be around sort of behaviours and adhering to role descriptions, etc. I don't know, Andre, I think you did some work around looking at that, perhaps, and Sheila, perhaps how that actually works in your local Healthwatch might be useful to reflect on. But yeah, I'm sorry, I don't think we've got a huge amount of that national. Andre?
Yeah, to add to that, I don't think we're particularly plugged in. So definitely, I think that's something for us. So great question, because I think that gives us something to go away and look at as well. In terms of that, yeah, kind of the second point. Yeah, we did. We've got things like codes of conduct. We've got examples. Again, you generally find that most of the local health watches have adapted it to their own or come up with their own volunteers. I can see Sheila nodding. So, but yeah, I think in terms of that being more prescriptive or being outlined nationally isn't something we currently have. And just to kind of clarify in terms of the way that Healthwatch works for anyone who doesn't know, is we're here to support the network. So we're not the commissioners, that sits at a local authority level. So we don't contract manage or performance manage the Healthwatch. So prescriptions like that would be an opt-in sort of model in terms of that. But yeah, Sheila, have you got anything you wish to add?
Yeah, probably just that bit about each local health watch is commissioned by their local authority. So here in Somerset, by Somerset Council. And so they are our commissioners, and therefore, we have regular meetings with them to check that we are meeting our contractual obligations. So of course, across the network, they will probably be slightly different in every local authority area. So I guess that, that question about, is there a national standard? Not really, because we're commissioned locally, therefore we have, so yes, there will be some national standards that we all adhere to, but very much, because of our commissioning and contracting is happening locally, that's where our contract sits. So that might look different in Somerset to what it looks like in Northumberland, Kent, etc. Does that partly answer that question? And then the other bit about the standards that we kind of adhere to. I think we work closely with the NCVO, as you said earlier, Andre. There are accreditations for people who are managing volunteers. So I think we kind of like to think we're aligned with those, and that's via the NCVO.
I suppose just to add to that, I suppose the only other thing that I would point out is we do have strict rules around enter and view. So that's where, so there's this particular activity that Healthwatch are able to, a power for local Healthwatch, and how that's actually done with named representatives, etc., and training to support them. That's something that we do absolutely have to support, and Healthwatch do that consistently.
Great, thanks all. I'm going to weave in the questions in the chat box with the ones that were submitted beforehand. So we've got two operational type questions that were very similar around the recruitment process for a Healthwatch volunteer. I wonder if, Sheila, we can go to you first with that.
Yeah, sure. So somebody contacts Healthwatch could be in a variety of ways. They might contact us via our website. We might be out and about and they say, oh, I like the sound of that. How can I volunteer for you? So the first process is getting in touch with us, and I would have a conversation with them, a very informal, over a coffee kind of chat, subtly to check out, what are their intentions, what do they want to do, how do they see, what do they think volunteering with us might be. So an initial conversation would happen. If they get past that barrier and they still want to join us and become a volunteer, then the next bit would be an induction. So we have a standardized induction whereby we tell them about Healthwatch, what we do, what our expectations of them as a volunteer are. So induction happens. Depending on the role that they're going to undertake, because a lot of our volunteers cross over multiple roles, so they might do everything that's on offer. They put their hand up and want to do it. So we have some volunteers that do everything. We have some volunteers that say, actually, I don't like going out and about. I don't want to talk to people out in the community, but I'm really happy to do something, using my laptop at home. So we've got volunteers who maybe, look through websites. We've got a couple of our volunteers who look at the Care Opinion website and take feedback relative to Somerset on that. So they help us with that. So depending on the roles, depends on whether they may need a DBS, because I guess that might be a question that comes up sometimes. Do your volunteers need a DBS? No, they don't. It depends on the work that they're going to be helping us with. When we carry out our visits to services to talk to people who may be vulnerable, then yes, those volunteers who are authorised to carry out that work, part of that authorisation is for them to get a DBS. Has that covered the recruitment?
That sounds very thorough. Thank you, Sheila. Thanks. We've then got a question from Freya, who's asking, what's the best way to get in contact with local Healthwatch branches to volunteer? Is there an easy route in for potential volunteers? It's probably you again, Sheila.
So I think either just put in Healthwatch, whatever, then, Healthwatch Wolverhampton, Healthwatch Herefordshire, Healthwatch Somerset, Healthwatch Croydon, type it in and you'll get a contact. You can then go on their website. Usually on the front page, there's a volunteer with us section. Virtually all our websites follow a similar pattern. So you can do it via a web form. You could ring them and say, I'm interested in volunteering. Can you tell me a bit about it? Yeah, or if people are not online or don't use a telephone, I guess, well, it would be a paper copy. Every Healthwatch would be able to send out a paper application form.
Great, thank you, Sheila. Then we've got a question from Rashpal. Do trusts ask to do their own checks? Are volunteers seen as Healthwatch volunteers or trust volunteers if they're on trust sites?
I'm happy to jump in. Yeah, go on, Gavin, if you're.
Yeah.
I was just going to say, yeah, so I asked the question whether interim view or otherwise, because if they're there on an interim view as a interim view representative, they are definitely there under the Healthwatch guide. As Gavin said earlier, there's quite strict adherence to certain things on interim view visits. So one of those will be having identification, which will be the Healthwatch identification. If it's other things such as helping out on, I see the clarity further on, such as the mental health wards. I would still imagine that if they're volunteering under Healthwatch, they will be under Healthwatch. But again, it may be down to, are they doing multiple volunteer roles? Are they also volunteering with the local NHS trust? What's the agreement with the NHS trust as well? Because obviously, depending on what sort of ward it is, it may be agreed that for the time that they're there, they're volunteering as trust staff, as trust volunteers, because it's easier to explain rather than why is there a third party organisation here not understanding. So sometimes it could be that as well.
Great, thank you, Andre and Gavin. Just as a lead on from that, there's a question from Jane. Do you seek any other checks, such as references and other ID checks? And are the roles DBS dependent?
I'm happy to come in there. I think that will depend on the roles, I suspect, because you know, I think as Sheila and Andre said, there's a whole range of roles, some of which don't need DBS checking. So if you're doing admin or things like that, you might not need to have a DBS check. But equally, if you're, and I think there are strict rules of, I think, around children and young people, particularly around like I don't think entering view can take place in a children's facility, for instance. So there's an example. But we do have strict rules around that. But similarly, I don't know, Sheila, do you want to come in and specifics around how DBS works in your Healthwatch?
Yeah, I think you said it there, Gavin. It depends on the role. You know, if anybody happens to look at the DBS website, that tells you all about it. It has to be the frequency of the activity you're carrying out and what that activity is. So for most of our volunteers, for most of the time, when they're, say, out in a library or a supermarket talking to the public, they don't need a DBS to be able to do that, even though what an individual might talk to you about could then be deemed as something quite personal and challenging. So that's why, you know, our volunteers at Healthwatch, we do have quite an amount of training, especially around talking to people and some of the things that people might tell you or confide in you. So, you know, there's always that kind of safeguarding question in the background. So, you know, if you are out in a GP surgery and somebody discloses something to you, what do you do? So our volunteers need to know about that. So that's something that we raise with them and we talk to them about. But they don't actually need a DBS to be able to go out and talk to people. It depends on the setting that they're going into, and that's things like, you know, is personal care being delivered, is help and care being delivered in that setting. If the answer to that is yes, then the next bit is about the frequency. How often are you going in there? And so there really is strict criteria around a DBS. So we don't just blanket DBS all our volunteers because it's not necessary. Is that
Sheila.
helpful?
I'm going to go to Jane because she's actually got a hand up. Hi, Jane.
Oh, hi. So my questions are coming from a place of just trying to understand from a volunteering perspective and those agreements you've talked about working with other organisations. So I'm also working with the Volunteer for Health grant kind of programme, and passporting for volunteers so that volunteers can move around and between organisations and what that looks like. So coming from an acute hospital trust, I'm very aware that we have traditionally followed certain processes for recruiting volunteers and that they can become a bit of a barrier. So my question about DBS was simply about some of the things that if a volunteer was going onto our wards and doing certain activities, then they would have a DBS. And if we were working with other volunteers, then there might be occasions when what they would be doing would require that. So you would be thinking about how to kind of move volunteers around. And I think that's what we're learning as we develop more and more volunteers in the kind of patient involvement piece, is just trying to be proportionate about what those volunteers need to have in terms of checks. So traditionally, and for good recruitment, that's you know, we would have 2 2 references we would do, because I see there's a comment in there from Sarah as well about occupational health checks. We would do DBS checks for certain roles, not for every, in different levels, and we would have had, like you say, an informal interview, and we would have done mandatory training. So it's really important for us that if we're using more and more volunteers, and we do really want to reach out to more volunteers, more people in our communities to come into our hospitals to help us with that, it's just trying to take a proportionate approach to what that looks like for volunteers, and our relationships and partnerships and trust in removing the barriers. And I know that's a lot of the work that you've been doing in Helpforce, Sally, isn't it? How do we kind of think a bit more innovatively and remove some of those barriers for volunteers moving? And we have a really good relationship with Healthwatch in Hampshire, so I do appreciate that, and they do come in, and we're increasingly working with their volunteers as well. But just a question I think that I think often comes up about volunteers coming in from another organisation into the NHS.
Yeah,
I
I think.
Thank
Oh,
you, Jim.
go on, Gavin.
I would say the response is, I think Healthwatch generally be wanting to work with you, so we don't generally there's no surprises around this stuff. The interim view is a power, and we can do it unannounced. We can do, but I don't think that's not the usual practice. Normally, we're absolutely wanting to work with providers. We have to make arrangements. So if you said volunteers needed to have a DBS check, they need a they need a DBS check, that sort of thing. So I think it's but I'll probably pass on to both Andre and Sheila to give you practical examples of how that works.
Yeah, I'm sure Sheila can probably, again, that's why she's here, give a real local view. As I'll use it again, lives and breathes this day in, day out. But I think what you said, Jane, is really, really interesting and really great, because obviously, the growth of volunteers and, the opportunities for volunteers is great. But as you say, it's those barriers. And if we're all doing different things, but in the same sector, in the same kind of realms, why are you doing something completely different to a local Healthwatch, and why isn't that aligned or at least similar? But I think every single Healthwatch, it's great to hear Hampshire working well together. We've actually got somebody on secondment working with us at Healthwatch England from Hampshire at the moment. And it's just down the road. I'm in West Sussex, so you're only down the road.
Yeah.
But yeah, I think it's those elements of if you speak to local Healthwatch, I'm sure they'd be more than happy to have that discussion and almost go, where are the variances, and can we meet in the middle? Is there a way of working? Or actually, can we just agree that, if we're going to try and work together closely, whether it's with other trusts as well, other wards, whatever it might be, maybe even other organizations, and come together and work together. That is what Healthwatch does. There is a lot of working together with other sectors, other PCSE organizations, and as we said earlier, co-producing, co-working is a massive part of what they do. Sheila, is there anything to add? Sorry, Jane.
Sorry, we haven't had any issues locally. What I suppose my context as well is thinking about how, if we're looking to seek more support from volunteers in general around patient involvement, then there's probably a more proportionate approach to what that looks like, so that people that are interested in working with us can come in and work with us and seek patient feedback in the same way that you do out in the community or when you come in. I suppose a lot of our traditional roles in volunteering are changing, so we do a lot of mealtime volunteers, we do chaplaincy volunteers, we do meet and greet, we do them in ED, but building our involvement network, if you like, of volunteers, like you say, that have got lived experience or want to get involved with us to help us improve our services. I was just interested in how you're doing that work already, what kind of approach you take to volunteer recruitment. So thank you.
I think if I can just add on to that, if Sheila's got something to add on as well, but I think part of that, when we come together as volunteer leads for Healthwatch, we've had many a discussion. I can think of discussions in the last 18 months that we've had about those sort of elements. And, sometimes it is about, whilst we've got those 12 kind of role descriptions, there's a wide range, as you said, about volunteer efforts and opportunities changing. A lot of people think, very traditionally, it might be your retired, people that have got a bit of extra time that want to come and do, a few hours here and there, or they're available in the day 9 till 5 when others aren't. But actually, we've got others that, are working wherever they want. And I can answer another question that's in the chat as we're going through this, is you can volunteer outside of your own local authority. So thinking about students that may live in one local authority, but whilst at university are studying in another, or you live on a border and would prefer to go elsewhere or wherever your local one is, absolutely fine. Some of it is completely remote. So we've had people that do, GP website checks, what's on offer, dental practices that are taking on NHS patients, things like that. So they can be done wholly online, wholly remotely, and at any time of the day. So again, I really like that idea of kind of rethinking what volunteers are and how they can be involved, because there is a wide range. And I'll come to Sheila just because she might have something to add on as well.
Yeah, just a couple of things. One, a reminder that we're talking about volunteers here. So, let's not forget they're volunteers. We mustn't make things difficult for them. So as soon as it gets into the realms of, oh, they need to, this much induction, this many training courses, they have to do all this paperwork, it starts to look like work, because it starts to get a little bit tedious. So I think we always must keep reminding ourselves, these are our volunteers, they're not paid members of staff, and that dividing line can sometimes be very tricky, because it can easily slip over into, oh my goodness, this is a real pain having to do this, submit another travel claim form, submit another thing. That looks like work. Remember, they're volunteering. So, I think for everybody in the room, probably you've probably felt that pain for some of your volunteers. We mustn't make it too difficult for them. We try not to put numerous barriers in the way to prevent people from volunteering with us, because otherwise it becomes difficult and they'll just, it will fail at the first hurdle. So let's never forget that we're trying to recruit volunteers, not paid members of staff. So how can we make it easy for them? And on that same thing, when I was just thinking about travel expenses, we reward our volunteers. We do pay their expenses. So any kind of travel or out of pocket expenses, so if they are in a supermarket doing a couple of hours of engagement activity, of course we would want them to go and get a coffee and a piece of cake, and we reimburse them for that, and we reimburse them for their travel. So we can't pay them, but we reimburse them for out of pocket expenses, and we try to make that as easy as possible. So, there's a paper form for those people who aren't online, and we do still have some of our volunteers who do not do things online. They do want a paper version of the travel expense claim form. So, that's my soapbox bit done. Thank you.
Thanks, Sheila. We've got a number of questions here. I'm going to try and get through as many as we can. So I'm going to go first to Sally Dyson, who's got her hand up. Hi, Sally. Sally, are you still there? You're muted at the moment. Okay, we'll come back to Sally. Leslie, who's put her question in the chat box, she did ask a question in advance, but she works for an ambulance trust.
Sorry, Sally. Oh, sorry, Sally. I was having problems with my camera and microphone.
Oh, okay. Do you want to fire away, Sally?
Yeah, I'm so sorry. Yeah, I wanted to just pop on really with regard to the discussion around DBS checks and recruitment checks and all the rest of it. Now, we all know, obviously, especially us working in acute organisations, that a lot of our VCSEs don't meet the CQC requirements for recruitment standards, and that's why we have so many issues around engaging VCSEs and external partners. our trust is actually taking a really pragmatic view to this, and we do check people, but we do it proportionately depending on who's coming in to actually and what they're doing, what they're engaging with. So we work really closely with Healthwatch Norfolk, and we do have a group of Healthwatch volunteers that come into the organisation, and they actually go on the wards to carry out place assessments, to actually speak to people to gain lived experience. And those people we do carry out additional recruitment checks for, but only because we have to meet that requirement of the CQC levels of recruitment checks for those people that are one-to-one engagement with our families and our patients. The other volunteers that we use through Helpforce and all our VCSEs, actually, all we do is create a memorandum of understanding, and I'm sure other people have done the same thing. And with that memorandum of understanding, we just ask the organisation itself to tell us how they recruit their volunteers, what their insurance cover is, etc., etc. And then we engage them as an independent organisation. So basically, they become responsible for their own volunteers' actions, and that's how we sort of safeguard and allow that slightly more easy flow of engagement. So our Healthwatch volunteers, for instance, the ones that just have online interaction with people, won't carry out any additional recruitment checks. We're happy that Healthwatch carry out enough, and they'll engage with our patients accordingly. For those obviously coming in, we will carry out some additional checks. So I just want to sort of clarify what we do around that, really, because I think it's quite helpful to actually think about an MOU, because it just gives you as an organisation an opportunity to engage people without having to go through that awful, painful double recruitment, and just trust the organisations that you're working with, that they're actually taking the correct steps to recruiting their volunteers. So I don't know if that's helpful, but yeah, I just wanted to sort of throw that in the mix, really. But I also wanted to just say that another way we've engaged with Healthwatch is they actually approach us often when they're doing discussion groups or focus groups, and ask us to supply volunteers for volunteering opinion. So it's quite nice that they actually engage with our volunteers and ask our volunteers to come on board to give their opinion about things that are happening in the health service. So I just wanted to sort of throw that in there as well, that it's a two-way thing. You know, they actually come and speak to us as well as us engaging with them. So yeah, a really successful relationship for us. So I just wanted to sort of pop that in the pot.
Oh, that's brilliant. Thank you, Sally.
No worries.
That's really brilliant. I know the work of Healthwatch Norfolk, and I know they take they work really hard at making sure that they're linked in with the trust, etc., and there's planning that kind of work. So that is a clear example where you've obviously sat down together and thought, well, how do we get that public experience about our services, and how do we have the assurance that, that the people who are going to be helping with that. So I think that is an example of, we said that critical friend bit, and that's the bit that they've got to get right. They've got to be independent, but they've got to be working with the trust, etc., to get that right. Certainly that's the kind of approach we really want to encourage right across the board. So it's quite good. We've got lots of people who are in that position to reach out to their Healthwatch and have a similar kind of conversation as you've obviously clearly had in Norfolk.
Great, thank you, Gavin. We've got 5 minutes left now, so we're going to do what we can. We may have to put some questions to you after the session, if that's all right, just to make sure we get answers for everybody. There was a question from Leslie from an ambulance trust around, because they cover such a large area, it's tricky to engage with all of the Healthwatch branches across that area. Is there a regional approach that could be adopted to make it easier to engage with the local health watches?
Yes.
Go on, Andre.
Okay, I'll go first on this one. So yeah, it's very dependent on each region. So we kind of have broken up into very broad regions, as in northeast, northwest, southeast, London, which we have meetings, or for example, I look after London, so anything within London remit, you could contact me, for example, and I can point you in the right direction. A lot of them all meet on an ICS basis as well. How regular that is and how often and what the agreements are is quite regional, and there is some variation. But if what I do, I'll pop in our link to our staff, which lists all our regional managers, and rather than just answering for Yorkshire, which I probably can't answer, Gavin probably can. I'm not very familiar. I live down the other end of the country, but the regional manager will be able to point you in the right direction, whether they meet regularly on an ICS patch or who specifically is leading for that area. So I've got some examples in London where somebody takes the lead for that ICS patch, or they have different project areas, or maybe it's just, if it's a bit broader, or there's several of you that all work in kind of our broader regions, then maybe it's about coming to one of our regional meetings as Healthwatch and having that discussion on a broader, more open conversation. But I've popped in the link so you can find all of our details and what regions we cover.
Brilliant. Thanks, Andre. Really helpful. Were you going to say something, Gavin? Sorry.
Yeah, just as an example, we did, the London Healthwatch actually did a lot of work for the ambulance service. And they would have used volunteers to help gather that insight, which then helped to inform their future. So that is the kind of thing Healthwatch often do.
Yeah, London
that takes
Ambulance
quite
Service.
A lot of coordination, but
London Ambulance Service had all 33 Healthwatch in London involved with their 5-year strategy. Which definitely involved their volunteers getting, patient voice heard, what's needed, and being able to take all that in across the entirety of London is, some achievement as well. Which is great because now, Healthwatch and that relationship with London Ambulance Service is fantastic. Anything that they want to help do either way, has become quite symbiotic in the terms of the kind of ways they work.
Brilliant. Thanks, Andre and Gavin. Quick question I'm going to squeeze in from Munya. What's the minimum age of volunteers that you take on board? Is that one for you, Sheila?
So our youngest volunteer currently is 16. However, we've done a couple of projects previously where we recruited a group of volunteers that we called our young listeners, because we did a specific project that was devised by them, carried out by them, and that was all around access to low-level mental health help. And so for a period of time, we recruited a group of volunteers, and they ranged from 13 to 17, age 13 to 17. We haven't recruited any volunteers that have been less than age 13.
Thanks, Sheila. I'm going to wrap up now. I realise there are a few questions still in the chat box, and but some really great comments as well for you to read through after the meeting. I just want to thank everybody for such great questions and for asking your questions directly as well. Really good conversation, and I feel as if I've certainly learned a lot more about the work of Healthwatch, and I hope you all feel the same too. Any questions that are still outstanding, I will put them to our presenters today to see if they'd be happy to answer some of those questions for us to share with the group. So I hope that's okay, everybody. But for now, thank you so much for coming today. Thank you to Gavin, Andre and Sheila for your amazing presentations and input. Really great to meet you all, and hope to see everybody soon on another network event. Have a great day, everyone.
And thank you for having us, and thank you for